Hey everyone, and welcome. Childbirth is obviously this incredibly profound human experience, but underneath it all, it's also a really precise and powerful biological process. So today, we're going to pull back the curtain on the clinical journey of labor and delivery. We'll break down the mechanics, the stages, and the common interventions step by step.
So, what is really going on behind the scenes here? It's so easy to just think of childbirth as one big event, but it's actually this fascinating cascade of coordinated mechanical and biological actions. And if you understand these hidden mechanics, you'll have a much deeper appreciation for the entire process. To really wrap our heads around labor, clinicians start with a super helpful framework. They call it the 3 Ps. Just think of these as the 3 essential elements that absolutely have to work in harmony for everything to progress smoothly. All right, first up, we have powers. This is the engine of the whole operation. Now, the uterus actually has small contractions throughout pregnancy, but true labor contractions, that's a whole different ballgame. They become organized, they get powerful, and they get progressively stronger, all with one goal, to open up the cervix and push the baby down. Okay, so you've got the engine. Next, you need the passageway. This is the path the baby has to navigate, right? It's the mother's bony pelvis and all the soft tissues around it. For a successful delivery, you need a good mechanical match. The baby has to be able to fit through the path. It's as simple as that. And that brings us to our third and final P, the passenger. And yep, you guessed it, that's the fetus. A few things are absolutely crucial here. The baby's size, its lie, which basically means whether it's up and down or sideways, and its presentation, meaning which part is coming out first. And what we're almost always hoping for is a head-down presentation. So let's just put it all together real quick. You've got the powers of the contractions, the passageway of the birth canal, and the passenger, the fetus. If there's an issue with any one of these three, it can slow things down or change the course of labor. It's this incredibly dynamic dance between all three. Okay, so now that we've got our key players, the 3 Ps, let's actually map out the journey itself. You see, labor isn't just one long, continuous event. It's actually broken down into distinct stages, and each one has its own specific purpose and its own clinical milestones. So here's the game plan, a bird's eye view. Stage 1 is all about getting the cervix open. Stage 2 is the actual delivery of the baby. Stage 3, the delivery of the placenta. And then you have Stage 4, which is kind of an unofficial but absolutely crucial stage. It's that immediate recovery period. So let's dive into each one, starting with that first stage. The first stage is what people usually think of as labor, and for good reason. It's typically the longest part. The whole point of this stage is for the cervix to gradually dilate or open to 10 centimeters. And it's driven completely by the building power of those uterine contractions. This slide, it just lays it out so perfectly. It shows you exactly how those powers we talked about really ramp up. Look at early labor. Contractions are pretty far apart, maybe every 5 to 7 minutes, and not lasting too long. But then you shift into active labor and boom, they're coming every 2 to 3 minutes, lasting much longer and generating way more pressure. That's the engine really revving up. All right, so here's something you hear all the time in movies and TV, right? The dramatic moment when someone's water breaks. But what does that actually mean from a clinical standpoint? And does it always just happen on its own like that? Well, sometimes a doctor or midwife will intentionally rupture the membranes. That procedure has a name. It's called an amniotomy. And it's not done just for dramatic effect, I promise. There are specific clinical reasons, like maybe trying to speed up a stalled labor or needing to put a monitor directly on the baby's scalp for a more accurate reading. And deciding to do one is a real clinical crossroads. There are clear pros and cons. On the plus side, like you see here, it lets you monitor the baby better, and you can check the amniotic fluid for stuff like meconium, which can be a sign of distress. But there are downsides. It can cause changes in the baby's heart rate, and here's the big one. It basically starts a clock. Once the water is broken, delivery usually needs to happen within about 24 hours to keep the risk of infection low. So once that cervix hits 10 centimeters, we are officially fully dilated, and our journey is heading into the home stretch. We're now entering the second stage, delivery. This is where all that hard work of the first stage pays off. The second stage kicks off at full dilation, and this is where things get really active. Now, it's not just the uterus's involuntary contractions doing the work. They're joined by the mother's voluntary pushing efforts. It's that powerful combination of two forces working together that finally moves the baby through the birth canal and into the world. But wait, the baby's out, we're done, right? Not quite. There's one more delivery to go. The third stage is all about delivering the placenta. The uterus keeps on contracting, and that causes the placenta to detach from the uterine wall. This whole thing usually happens within just a few minutes. Now, with that detachment, some bleeding is totally normal and expected. We're talking about 500 milliliters on average, which is about half a liter. And that might sound like a lot, but the body is actually super prepared for this. Blood volume increases by a huge amount during pregnancy to compensate for exactly this. And that brings us to the so-called fourth stage, that first hour right after delivery. This hour is absolutely critical. The number one concern here is postpartum hemorrhage or excessive bleeding. To prevent that, drugs like oxytocin are routinely given to make sure the uterus clamps down really firm, which closes off the blood vessels where the placenta used to be. Of course, not every labor follows this exact map. It's not always a straight line from A to B. Sometimes you get detours, and that's when clinical interventions become necessary to make sure everyone stays safe and healthy. One of the most common detours is something called dystocia. It's just a clinical term for a difficult or stalled labor. And it goes right back to our 3Ps, doesn't it? It can be caused by a problem with the powers, maybe the contractions aren't strong enough, the passageway, if the pelvis is too small, or the passenger, if the baby is in a funny position. And look at that statistic. It is the single biggest reason for C-sections in the US. Another common intervention is induction, basically kickstarting labor artificially. And it's really important to know there are two different types. An indicated induction is done for a clear medical reason, like high blood pressure. An elective induction, on the other hand, is done more for convenience, and it has some very strict rules. Like you have to be at least 39 weeks pregnant to make sure the baby is fully cooked and ready. Okay, now for a very serious, but thankfully pretty rare complication. Sometimes right after the baby's head is delivered, it kind of seems to retract back a little bit. This has a really descriptive clinical name. It's called the turtle sign, and it's a huge red flag for a medical emergency called shoulder dystocia. So what the turtle sign is telling us is that the baby's front shoulder has gotten stuck behind the mother's pubic bone. This becomes an emergency situation, fast. Why? For a few critical reasons. It can squeeze the umbilical cord, which cuts off oxygen. Plus, the maneuvers required to get the baby unstuck can, unfortunately, sometimes cause injuries like nerve damage or even fractures. It requires a really calm, coordinated, and rapid response from the whole team. Wow, we've just navigated the entire clinical map of childbirth, haven't we? From the 3Ps, through all 4 stages, and even explored some of those unexpected detours. Understanding these mechanics really gives you a whole new level of appreciation for the precision of this natural process, and of course, the importance of skilled medical care. But it also leaves us with a bigger question to think about. How does knowing all this clinical detail change your perspective on what is, for so many people, one of the most profound human journeys of all?
You know, for generations, medical advice about childbirth felt like it was carved in stone. But what happens when a belief that's been held for so long just gets flipped on its head? Today, we're going to break down the massive shift in thinking around vaginal birth after C-section, or VBAC, and what it all means for how we approach childbirth today. For decades, this phrase was pretty much medical law. I mean, it was gospel. If you had one C-section, it was just assumed that every baby after that would have to be a repeat C-section. This was taught in medical schools, practiced everywhere. But as you're about to see, that old rule, it's just not true anymore.
So, what changed? Well, our medical understanding got a whole lot better, and it started to poke holes in that old, rigid way of thinking. The reality now is way more nuanced, and it gives parents choices that, frankly, just weren't even on the table before.
Okay, to really get this, we've got to nail down 2 key acronyms, TOLAC and VBAC. They sound similar, but they're different. TOLAC stands for Trial of Labor After C-Section. Think of this as the process. It's the attempt to have a vaginal delivery. Now, VBAC, or vaginal birth after C-section, is the successful outcome. So you go through a TOLAC in the hopes of achieving a VBAC.
Now you might be asking, why the big push for this change? Well, the motivation is actually pretty huge. A C-section is the single most common major operation performed in the entire United States. And you want to know the #1 reason for getting one? It's because you've had one before. This created a cycle of repeat surgeries. So exploring VBAC became absolutely critical, because it offers a way to break that cycle, a chance to avoid another major abdominal surgery.
All right, so this all leads to the $1 million question, right? Who is actually a good candidate for a trial of labor? And let me tell you, this is not a one-size-fits-all kind of deal. Picking the right patient is probably the single most important factor for success.
Let's tackle a really big one first. A lot of people think that if their first C-section happened because labor stalled out, what doctors call failure to progress or dystocia, then it's just bound to happen again. But guess what? Most studies actually show a really high chance of success with a trial of labor, even for these women. So a tough first labor doesn't automatically kick you out of the running.
Okay, now there are some situations that are more of a gray area. The things you see here don't mean you can't have a TOLAC, but they absolutely require a really deep conversation with your medical team. Stuff like carrying twins, going past your due date, or having had more than one C-section. All of these add layers of complexity that you really have to weigh carefully.
And then we have the absolute deal breakers, the times when a trial of labor is just not considered safe. This includes things like a previous uterine rupture, or having a certain type of old incision on the uterus, like a classic or T-shaped one. And this last one is so important. If the hospital isn't set up to do an emergency C-section with a surgeon and anesthesia team right there ready to go immediately, then a TOLAC should not even be attempted. Safety has to be number one.
So, if someone is a good candidate, what does the whole process actually look like? How is it managed? This is where we get into the nitty-gritty and also tackle a really common fear about pain. Look, a safely managed TOLAC is all about being prepared and watching everything like a hawk. This means getting an IV in right away, continuously monitoring the baby and the contractions, being super careful with any drugs to speed up labor, and like we just said, having that emergency team literally immediately available to jump in if anything goes sideways.
And this brings us to a huge historical fear. For the longest time, the conventional wisdom was that getting an epidural during a TOLAC was a bad idea. Why? Because the fear was it would cover up that very specific telltale pain of a uterine rupture, and doctors would miss it until it was too late.
Well, here's mythbuster number one. It turns out those classic symptoms like sharp pain or tenderness, they're actually really unreliable for diagnosing a uterine rupture. In other words, just waiting for a patient to feel a certain kind of pain is not a safe or effective way to catch this rare but very serious complication.
And that leads us straight to mythbuster number 2. Tons of studies now show that epidurals can be used safely and successfully during a trial of labor. In fact, some doctors even prefer it. Think about it. A patient who isn't in agony is easier to assess, and if an emergency C-section is suddenly needed, that epidural is already in place and ready to go.
Okay, so we've talked about who's a good candidate and how a TOLAC is managed. Now let's look at the bottom line, the outcomes. What are the real risks and what are the real rewards?
The complication that everyone worries about most is uterine rupture, so it's really important we put this number in context. The approximate risk for a well-chosen candidate in a planned TOLAC is about 1%. So while it's a very serious risk, it's also a very rare one.
This right here really shows you the two sides of the coin. On one hand, you have a successful VBAC. That's a huge win. You avoid major surgery and all the risks that come with it. But on the other hand, an unsuccessful TOLAC, one that ends in an emergency C-section after a long, hard labor, that scenario actually carries the highest risk of all for complications like infections or heavy bleeding. And this quote from the source material drives that point home. It's not the trial itself that's the problem, it's the unsuccessful trial. And this just hammers home why it is so important to get the candidate selection right and to make sure the hospital is ready for anything. You want to stack the deck for success right from the very start. So really, here is the bottom line, the take-home message of all of this. Success and safety with a VBAC attempt boil down to two things that have to go together. First, a well-chosen candidate who's been carefully evaluated. And second, a well-prepared hospital that has the people and the resources ready to move in an instant if they're needed. Both of those things are totally non-negotiable.
And that kind of leaves us with this final big question to think about. The whole story of VBAC is a perfect example of this delicate dance that happens in medicine all the time. How do we honor a patient's choices and their right to decide, while also carefully managing real medical risks? It's a conversation that's constantly changing, not just in the delivery room, but across all of healthcare.
Hey everyone, and welcome. Today, we're going to dive deep into the anesthetic management for labor and delivery. Our goal here is to break down all the key principles for providing safe, effective pain relief in a really clear, structured way. So let's get right into it.
So here's our game plan for today. We're going to start with the big picture, the fundamental goal of what we're doing. Then we'll get into the real nuts and bolts of dosing, first with local anesthetics, then with opioids. After that, we'll cover a pretty cool specific technique for the second stage of labor, and finally, we'll take a look at some alternative blocks. Think of it as building a solid foundation piece by piece.
All right, first up, the goal of labor analgesia. Before we even think about touching needles or drawing up drugs, we have to be absolutely crystal clear on what we're trying to accomplish, because once you really get the why, every decision you make after that just falls into place. So what does that ideal outcome actually look like? Well, it's really a careful balancing act between three key things. Number one, obviously, is effective pain relief. But number two, we have to do that with minimal or even zero motor blockade. We want the patient to be able to move and participate. And number three, and this is a big one, our technique cannot, under any circumstances, have depressant effects on the fetus. These three principles, they guide absolutely everything we do. Okay, let's move on to the foundation of the epidural block, dosing with local anesthetics. Honestly, getting this part right is everything. And we're about to look at the single most important factor that determines whether your block is a success. And here it is. This is the one thing I really want you to burn into your memory. It's the volume of the solution, not its concentration. That's the key factor in determining the height of your block. The amount of liquid you inject is what dictates how many spinal segments you're going to cover. This is an absolutely fundamental principle. So how much volume are we actually talking about? Well, the magic number, our go-to rule of thumb, is 1 to 2 cc's. But what does that number actually mean for us in practice? It means this: for every single dermatome level we want to anesthetize, we're going to need about 1 to 2 cc's of our local anesthetic solution. That's our dosing guideline. It's awesome because it means we can just count the number of dermatomes between our catheter and our target level, and we can calculate the exact volume we need. Which, of course, brings us to a really important question. Why T10? Why is that our target sensory level? Well, I want you to think back to your anatomy. What nerve roots are carrying those pain signals during the first stage of labor? That T10 target is all about making sure we cover the uterine and cervical nerve pathways. So, let's put it all together and walk through a quick example. Let's say your catheter is sitting pretty at the L3-L4 interspace, and your goal is to get to T10. You literally just count up the levels: L3, L2, L1, T12, T11, and T10. That's about 6 to 7 dermatomes. So you take our guideline, let's use 2 cc's per level, and multiply. That gives you a total loading dose of about 12 to 14 cc's. See? It's that straightforward.
Now, once you've got the block established, how do you keep it going? Well, we basically have two main approaches. On one hand, you can manually redose, giving a bolus whenever you need to before the pain comes back. This usually involves a higher concentration of drug. On the other hand, you can hook up a continuous infusion pump. This is great because it achieves a really nice steady state of pain relief and lets us use more dilute solutions, which is fantastic for minimizing that motor block.
Okay, next up, let's add another tool to our kit, neuroaxial opioids. So if we add just a tiny amount of an opioid into our local anesthetic, something really cool happens. It's a synergistic effect. It's like they help each other out. It makes the pain relief feel so much better and allows us to use lower concentrations of the local. And that, in turn, helps us minimize side effects like motor block and that drop in blood pressure from sympathectomy.
But here is the thing. Not all opioids are created equal, not even close. The huge difference is whether they are hydrophilic, meaning water-loving, like morphine, or lipophilic, fat-loving, like fentanyl. Just look at this chart: the onset, the duration, and most critically, the timing of potential respiratory depression. This isn't just trivia, it's a massive safety distinction that will directly impact your choice of drug.
If there's one thing to remember, it's this little mnemonic. Hydrophilic drugs, like morphine, tend to hang out in the cerebral spinal fluid for a long time. They slowly migrate upwards towards the brainstem, which is why the danger is late respiratory depression, maybe 6 to 12 hours later. Lipophilic drugs, on the other hand, are absorbed into fatty tissues super fast. So if you're going to see respiratory depression, it's going to be early, within the first 2 hours. So for quick relief during labor, you'll probably reach for fentanyl, but you have to be ready to monitor closely right away. For long-lasting pain relief after a C-section, morphine is a great option, but your monitoring plan has to last for many, many hours. All right, let's switch gears to a very specific and kind of cool technique, the perineal sitting dose. As your patient moves into the second stage of labor, the pushing and delivery part, the pain shifts. It moves downwards. So we need a way to get dense anesthesia right to those sacral nerve roots, and this targeted dose is exactly how we do it.
Now, when we're picking a drug for this specific job, we have to think about its chemical structure. Are we using an ester or are we using an amide? And you might be thinking, why does that even matter? Well, it matters a whole lot. It comes down to how the drug is metabolized and the potential for a very specific kind of adverse reaction.
And that brings us to 2-chloroprocaine. It's a fantastic drug for this perineal dose. Why? Well, for one, it has the fastest onset of any local we use in an epidural, so you get really fast. And two, it has a super short duration, so motor function comes back quickly after delivery. But here's the key thing to remember. It's an ester, and that means there's a small but very real risk of allergy. This is why you absolutely must screen for a history of ester anesthetic allergy every single time.
So we know the epidural is our gold standard, but let's be realistic. It's not always possible, and it's not always the right choice for every patient. So we have to know our plan Bs. We need to be familiar with some alternative regional techniques for pain relief.
And let's start with a little history lesson. The paracervical block. You really need to know about this one, mostly to understand why we never ever do it anymore. It provides an incredibly important lesson in how patient safety has evolved.
I mean, just look at the reasons this block was abandoned. The injection site is dangerously close to the uterine artery. This led to vasoconstriction, which cut down blood flow to the placenta. It also caused high levels of the local anesthetic to get into the baby's circulation, which resulted in a really high rate of severe fetal bradycardia. It's just a stark reminder that our number one job is to protect both mom and baby.
Now, let's look at a modern and very useful alternative, the pudendal block. This is a really neat block that's often performed by the obstetrician right before delivery. They use a special needle to get right underneath the ischial spine and anesthetize the pudendal nerve. And this provides fantastic perineal pain relief for the delivery itself and for any repairs afterwards, all without the big systemic effects of an epidural.
So that really brings us to our final thought for today. We've gone through epidural dosing, adding opioids and a couple of alternative blocks. We have this whole toolbox of options available to us. The real art of obstetric anesthesia is knowing which tool to pick for the right patient at exactly the right moment in their labor to achieve that ideal outcome we talked about at the very beginning, a safe and positive birth experience. And that right there is both the challenge and the incredible reward of what we do.